Get started. Michelle, can you start recording, please? All right. Welcome to the first meeting of the Technical Advisory Group for the Cost Growth Target Program. I think most of you should have received the meeting materials via email earlier this week, but just in case you didn't, they are posted online and you can find them with this link on the first slide. Just a little bit of housekeeping before we get started today. This meeting is being recorded. The recording will be posted on the TAG website as well as a brief meeting summary. And then just Zoom meeting etiquette. Please list your first and last name and organization on your name just so we know who's here. And we have disabled the chat function for the call. If you have any questions or having technical difficulties, you can check in with staff, but we're not going to have any chat about the meeting topics. Feel free to come on or off camera, whatever is most convenient for you. No specific preference there today. So I'm going to run through the agenda for today real quick, and then we will do a round of introductions because this is our first meeting and want to figure out who all we have participating. So we'll start with introductions. Then I'm going to give a little bit of background on the healthcare cost growth target and how the program and the implementation committee led to this technical group. Trang will walk us through the charter and the work plan, and then we will introduce the data submission template and the temporary rules, both of which are our first lifts as a technical group. And then we'll talk briefly about next steps. So that is the plan for today. And let's go ahead and jump into introductions. I am going to call down the list of who I see on the screen. And if you can just introduce yourself, your name, your organization, and your role, that would be great. So I'll start. I'm Sarah Bartleman with OHA, Oregon Health Authority. I am the Cost and Coverage Policy Manager, and I am the lead for the Cost Growth Target Program. All right, and going down my list, first up, I see Trang.
Hi, everybody. My name is Trang Weidemeyer. I'm a program analyst with the APAC program, the Oregon's All Payer All Claims database. Some of you may recognize me, and I recognize a couple of your names if you've ever attended any of our APAC tags, or if you were involved in the payment arrangement file work group. Hello again. And Sarah, I'll hand it back to you to go down your list.
All right, Rachel.
Hi, everybody. Rachel Block, Program Officer with the Milbank Memorial Fund. Real pleased to be here today. We're really interested and supportive in all of the work that Oregon is doing here, but in particular, Oregon's participation in the Peterson-Milbank program for sustainable healthcare costs. So I'll look forward to the discussion.
Thanks for joining, Rachel. Richard.
Hi, I'm Richard Gibson, a physician informaticist with Comagine Health, and Comagine Health has been involved in total cost of care at the PCP level for about 6 years. Thank you.
Stephen.
Hi, I am Stephen Ranzoni. I'm a hospital policy advisor with the Oregon Health Authority, and I help support this program.
Thanks. Ishan.
Hi, I'm Ishan Song. I'm a research analyst. I will mainly work on the data with our cost growth target program. Thank you.
Mark.
This is Mark Hetz. I'm the Executive Director for HIT Commons, which is a subsidiary of Oregon Health Leadership Council, who is providing some assistance on the cost growth target work. Thank you.
Megan.
Hi, everyone. This is Megan Burns. I'm a senior consultant with Baylett Health. Baylett Health is working with the Milbank Memorial Foundation and Peterson to supply technical assistance to Oregon and a couple of other states on the healthcare cost growth target.
Thanks. Mark.
Hi, good morning. Mark Florian, VP and Chief Actuary with Pacific Source. Thank you.
Rika? Am I saying?
Rika. I'm Rika with the Oregon Medical Association. I'm not on the advisory group. I'm just observing.
Great, thanks for joining. Gail?
Sorry for the delay. I'm Gail Woods. I'm a Senior Policy Advisor with the Division of Financial Regulation within the Department of Consumer and Business Services.
Great, thank you. Bernie?
Hi, I'm Bernie Inskeep. I am the APCD Program Director for United Healthcare.
Thanks for joining. Jim?
Hey, Jim Gardner, and I'm Chief Operating Officer for Advanced Healthcare, CCO, in Southern Coast, Oregon.
Welcome.
Thank you.
Zachary?
Good morning, everyone. Zachary Goldman, Economic Policy Advisor at OHA.
Kristen?
Good morning, Kristen Downey, Government Affairs for Providence.
Mary Beth?
Hi, I'm Mary Beth Garino. I'm the healthcare advocate with OSPERG. We're a consumer advocacy public interest organization with members across the state. I'm really excited about being here.
Cable?
Good morning, Cable Hogue, Implementation Analyst and Federal Policy Liaison for the Oregon Health Insurance Marketplace within the Department of Consumer and Business Services.
Amy?
Hi there, Amy Clary. I'm the Research and Data Manager within the Office of Health Analytics at OHA.
Jared?
Hi, I'm Jared Collings with Cambia Health Solutions. I'm Assistant Director in the Healthcare Informatics Group. Happy to be here.
Welcome. Ben?
Hi, Ben Chan, Research Analyst with the Oregon Health Authority.
Melinda?
Hi, I'm the project lead with Aetna for the Oregon APAC.
Great. Welcome. Vince?
Hi, Vince Porter with Cambia Health Solutions. I handle government affairs. Jared Collings will be though our on the formal group. I'm just listening in.
Great. John? No, John. Daniel?
Good morning, I'm Daniel Porter. I'm the Vice Director in Population Health.
Great. Daniel, you sound like you're in a tunnel, just so you know. David?
I'm a retired health economist, and I've been tracking both this task force and the task force for universal health care. And I'm a data guy from 30 or 40 years of experience.
Great. Peter?
Hi, I'm Peter Woodlake. I am a legislative assistant for Representative Maxine Dexter. I'm just here to take notes on her behalf.
Great. Welcome. Andrew?
Good morning. I'm Vice President for Financial and Actuarial Analytics at Providence Health Plan.
Thanks for joining. And Dean? All right. Did I miss anybody?
Yes.
Go ahead.
I finally got connected. I'm Jack Schaff. I'm a retired consumer, and formerly I spent 30 years with the U.S. Public Health Service, and I spent the last pandemic in San Francisco during the 1970s and 80s.
Thank you for joining. Did I miss anybody else? All right, I'm going to ask everyone to put yourself on mute if you can. And just a little bit of a note, this is an open ad hoc group, so we don't have appointed membership, appointed seats, and I expect our membership will fluctuate a little bit depending on the topic that we are addressing and who the right folks are from all of your organizations to participate in that discussion. Some of you might be serving as the primary point of contact and you'll coordinate internally and then bring any information back to the group. Others of you may want to pull in others at your organization and have multiple perspectives for the discussion. Both approaches are totally fine, but we will have a little bit of an evolving group. We also anticipate that this group will be a little less formal than our implementation committee and some of our other committee work. So folks who are listening in, you are welcome to participate, but we may facilitate as needed to make sure that we're getting through everything that we need to do today. All right. Moving into our first agenda item, we wanted to just make a little space to talk about the Healthcare Cost Growth Target Program and the work of the Implementation Committee and everything that led to the creation of this tag and the work for 2021. I know a lot of you have been following the work of the Implementation Committee and have seen presentations or participated in educational webinars or listened into committee meetings. So I don't really want to spend a ton of time repeating all of that. I want to cover just a couple of basic points on the next slide. And then I thought I would open it up to see if there are any questions about the background or the context rather than doing a whole sort of 101 presentation for you all again. So a couple of highlights about the basics. The Cost Growth Target Program will include the annual measurement of total healthcare expenditures. We will compare year-over-year growth to the established target. The target was set by the Implementation Committee. We're starting at 3.4% for the first 5 years. In the second 5 years, that will drop down to 3.0%. The cost growth target will be measured at 4 different levels. So statewide, by market, Medicaid, Medicare, and commercial, by payer, so insurer, United, Aetna, Providence, and then by provider organization. And when we're talking about providers for the Cost Growth Target Program, we're not talking about individual clinicians, we're talking about those large organizations, so health systems, practices, and medical groups. And we are working on some additional documentation and detail about sort of who that is. And we can talk about that later if we need to. The data submission for the program will be coming from payers. We will be asking you, those of you payers on the call, to submit the data files that include the total healthcare expenditure calculation. That is what we use for calculation of the cost growth target at all 4 of those levels. We will use other data like our all payer claims data for supplemental analysis, understanding key cost drivers, all that good stuff. The first measurement year is 2021, so we'll look at the cost growth between 2020 and 2021. We know off the bat that that's probably going to be a little unusual because of COVID, and so there are some safeguards that the Implementation Committee has put into place, considerations for why cost growth may be higher or lower than the target and when that's okay. The data for 2021 and that first official measurement year will be submitted in 2022. But in the meantime, we are going to be collecting data for 2018, 19, and 20. We'd like to collect that data a little bit later this year. That'll be our opportunity to test out the data submission and validation process, work through all the details of the measure of the data submission specifications, and that will all provide some really important context for cost growth trends in Oregon, both before COVID and then the impact of COVID in Oregon. I think we've been referring to this a little bit as the baseline data, but I want to be really careful with that language. It's not a baseline in that it's the baseline that we then measure against for the target performance. It's baseline in terms of context and foundational information. So that was a whole ton of information I just dropped on you. I recognize a lot of your names from committee meetings and other webinars and presentations. So do folks have questions? Is there anything more specific about the Cost Growth Target Program backgrounds that we could talk about before we launch into the work of the Technical Advisory Group? Are you all feeling pretty comfortable? What do you think?
This is Drew Tarrant from Providence. Just a reminder, folks, where I'm from. And I go by Drew, not by Andrew. The cost growth target at the market, payer, and provider organization. I actually have two questions. One, will any consideration be given for shifts in payer acuity? Population acuity or demographics? And then two, just want to confirm at the provider organization, it's actually still total person measurement, right? It's people connected to, say, like Providence or Legacy and their total cost, not just the cost at Providence or Legacy or OHSU, right? Is that accurate?
So let me take your first question first. Consideration for shifts in population acuity. Yes, the data that will be submitted will be risk adjusted. So each payer will be able to risk adjust using their own risk adjustment methodology. The implementation committee discussed whether or not that should be a standardized statewide risk adjustment methodology and ultimately decided we weren't ready for that. So each payer can use their own risk adjustment and just let us know what that is, and that'll be part of the data submission and documentation. In terms of provider organization, person measurement, yes, it is. Each payer will report on their enrolled members that are attached to that provider organization, and that will be through a primary care-based attribution method.
Thank you.
Other questions, background, thoughts?
Yeah, Sarah, this is Jared Collings from Cambia. I had a similar question, maybe about the attribution method. You mentioned that it's a primary care attribution model, which doesn't attribute everyone in our population, and obviously only attributes to those primary care type physicians and clinics. So was that all talked about and discussed? And is there any additional reference material on that attribution? And if it's a topic we'll discuss later, I'm happy to wait.
Yes, all of the above. Thanks, Jared. That's a great question. So it is primary care based. No, it will not attribute everyone in the population. We will talk about this more when we start reviewing the data submission template later in this meeting and definitely next month.
Okay.
But just a couple of preview notes. Each payer will use their own attribution methodology. Similar to risk adjustment, we thought, can we get sort of a standard attribution statewide? And we probably can't, given our timeline and the lift. So it'll be your own attribution models, primary care based. It will not attribute everyone in the population. So there will be provider organization 1, all attributed patients, provider organization 2, all attributed patients, and then a row in the data submission template for all unattributed. And we'll talk more about that in the template shortly. Other thoughts, questions? I think the questions that Drew and Jared just asked are exactly the reason that we are going to exist as a technical group. The implementation committee set up a number of parameters for us to work with, but the actual specifications have not yet been finalized. And so these are the things that we'll be working through over the next couple months.
Sarah, this is Dean Andretta. Can I ask a question? Oh, hi. So you mentioned on the cost growth target, the measurement that provider organizations, and obviously for provider organizations, the payers' costs are their revenue. So health systems, and I sort of get hospitals have Medicare cost reports. Is that what you're talking about there, or their revenue that they're receiving from these various payers that you're talking about?
Yeah, so I'm not, Dean, I'm not sure if I'm going to answer this exactly the way you're asking, and I'm going to ask other members of the team to help me out in case I say this wrong. But we're measuring total healthcare expenditures in 2 different ways. So at the payer level, it's total healthcare expenditure, THCE, and that includes revenue, things like admin. On the commercial side, net cost of private health insurance. when we go down to the payer level, or sorry, when we go to the provider organization level, we go to measure total medical expenditures. So we'll not include some of those payer costs, will not include some of the pharmacy rebate costs that accrue at the payer level. It will be the dollars that the payer pays to the provider organization. Megan, Zachary, team, anything to clarify there?
No, I think you got it, Sarah. I think the idea is that the locus of focus is at the provider level, and it's what dollars are being paid to providers from payers. So that will not include any sort of capitation or premium payments that are made between a Medicaid, for example, between Medicaid and a CCO. But it would be any of the CCO payments, for example, to a provider entity. And then the net cost of private health insurance, which is a calculated figure that covers essentially admin and margin or contribution to reserves, is measured at the state and the market level and the payer level.
Okay, yeah. So, I mean, provider, it's cost growth target. So having a provider organization represent their cost would be something different than their revenue.
Yes, that's right.
Just don't confuse there.
Yep. Go ahead, Megan.
I was just going to say, yes, terminology when it comes to costs and prices and spend and revenue get often jumbled up. There will be, there's not going to be a measurement, for example, of what it costs, like in terms of cost accounting for a hospital, for example, to operate a particular service or unit. That is assumed it's covered through the payments that are made from payers to the providers.
And to add to that, I think one thing that came up in a number of the implementation committee conversations, on the policy board conversations, is there are a number of things that we want to measure to understand what's happening. And those are what I call the supplemental analysis or the exploratory analysis to look at costs and cost drivers. So it may be that we want to do some analysis of that, more of the cost accounting, or dig into the Medicare cost reports for hospitals. Some of that is already going on, some of that we will develop. And that is all essentially ancillary to the measurement of the total healthcare expenditures and the total medical expenditures, which will come from this new payer data submission that we're going to be developing. My cat is joining this meeting, sorry. Other questions?
Thank you.
Are we ready to move on? Go ahead, Dean.
I just said thank you. I'm good.
Great.
Sarah, one more question. This is Jared from Cambia again. When you talked about data collection, is it at multiple times during the year? Is there specific run-up periods or ability to restate if we get future claim adjudications that would impact prior submissions? And just hoping you'll talk about that.
Yes, definitely. We will talk more in detail about that too, but quick highlights. It will be an annual data submission. There will be a fixed schedule. Right now, we're thinking mid-August would be the deadline. That would allow about 6 months of claims run out, assuming 6 months of claims run out. The way that we're thinking about the locking of the data or the resubmission for any adjudication, that data submission will be sort of the official final input for the year. We wouldn't be asking for a resubmission sort of continually or quarterly to correct data. We know that things do shift, but this will be a point in time lock-in of the data file. There are a couple of exceptions to that. So for example, if a payer changes their risk adjustment methodology or their attribution methodology in 1 year, we would ask them to recalculate and resubmit previous years using the new methodology so that we can continue to trend everything appropriately.
Sarah, this is Drew. it sort of opened up a bit of a can of worms here, perhaps, because some risk arrangements between payers and providers have longer tails than that.
Yep.
Would we, partly to account for things like RADV audits that, for just settlements between us and the government that just take forever to happen, that get passed on to providers. Should we just, I guess, will we have guidance as to use our best accrual and then we'll allow for no retro change after that period? Is that, in other words, this doesn't have to be on a paid basis. It could be on an earned basis.
I think we want to focus on paid basis. I think we should talk about this more for sure. We definitely will provide guidance on how to handle this. I think we've been looking to Massachusetts and how they are structuring their data submission timeline, and they actually do a preliminary submission and then a final submission. So they calculate everything twice, and so they do allow a longer run out. They actually told us that they regret setting it up that way, maybe not in those words, but that it caused a lot of complication. And so we're trying to split the difference between having some run out, but also having data not lagging 3 years by the time we're able to report it. So we're thinking 6 months. It's not perfect. It won't capture that tail for everything, but it does hopefully capture the majority. And we can talk about instances where that's not the case or where we might need to handle things differently.
But if we made an accrual for that longer tail, we can include that accrual, is what I guess I was asking.
I want to say yes, but I also think we probably need to talk about the details more. Megan, do you have thoughts?
I would just say in the other states that are doing it, there is an IBNR, IBNP calculation, and at least in Rhode Island, we ask payers to estimate, what % of spending is estimated. So
it sounded like the question was more to the non-claims expense portion than the claim piece. And the non-claims expense is going to be the more challenging one to estimate.
I mean, you're right, Jared. It was about the non-claims expense, but we would have, in this case, it would be an IBNP on the non-claims expense that we could estimate, that is estimatable.
This is great. These are the kinds of questions that we want to get into and help figure out what needs to be called out in the guidance and what needs definitions or what needs additional detail worked out. I think we will continue to flag these types of questions, but it sounds like I'm not hearing anything that's sort of foundational, like why do we have a cost growth target? So I think we should keep going right into the details, and I want to hand it over to Trang to talk about the charter and the proposed work plan for us as a group. Everyone good with that? All right, go ahead, Trang.
All right. And yes, these are really good questions you're bringing up, and that's exactly why we have these tag meetings all through this year. Okay. So the charter and work plan. I don't know if Michelle, you want to throw up the charter really quickly, or people? It's attached to the meeting information. So if you look at that link that was sent to you, you could pull it up right there. So I'm just going to go over this very, very quickly. As Sarah said before, this is a distinct body from the implementation committee. This will be giving advice and to that committee and the future governance committee that will take over. And our scope is pretty defined. Can you go to the next slide, Michelle? Can we forward the PowerPoint slide? Okay, I'll just go on. The PowerPoint slides are included in the tag meeting for today as well. So thank you. Those links are also very helpful as well. So going on to the purpose. Thank you. And Sarah outlined that very well. So let's just go down to scope. I'm going to reiterate this tag is not a decision-making body, and it's an advisory body, and roughly we'll be working, the two big projects are the rules and the data template and specifications all throughout this year. This is a venue for discussion and getting into the nitty-gritty details of how we are going to operationalize the data submission to carry out the program. Next slide, please. And I won't go down this whole list, but in the charter, it also outlines some broad topics this tag group is going to touch on. A lot of it is very much tied to the submission template, the specifications, how OHA is going to validate it. All of this information will be discussed and provided for you all here. Okay. Next slide, please. This membership is open to any interested parties. We do ask that each payer, each submitter organization should have at least one tag member join us for these tag meetings, but we are not limiting membership to specific roles or number of people from organizations. So please forward the meeting invites and any information to other team members. And of course, provider organizations, consumer representatives, employer representatives, also welcome to come. Okay. All right. So let's go to, oh, can you go one slide up? To tag meetings. So we will be meeting monthly throughout this whole year. Afterwards, we'll see where we land and the type of activity that this group is needed for, and figure out the frequency of meetings beyond that. We'll do all of these meetings virtually, and they're all open to the public. Michelle, actually, can you pull up the work plan?
While Michelle's doing that, I want to make a quick plug for the distribution list. So we will send out public meeting notices about each monthly tag meeting, but we will send out materials and other details to the discussion or to the distribution list. So I think most of you are already on the distribution list. I have your email, but if I don't, if you're joining today based on the public meeting notice, or if someone tagged you in for this, please let us know if you would like to be added, or if there are others in your organization that you would like to be added to that list as well. You can just send us a quick email with any names and email addresses that should be added.
All right, and while you're pulling up that work plan, I'll just, oh, thank you. All right, so you can see here, I think we have almost the whole year mapped out. And you'll see these are on the right-hand column, these are the deliverables we'll be sending to you to prepare for discussion during that month's meeting, and then the next couple meetings too, if needed. So the first item you'll see we want to hammer out right off the bat is the temporary rule language, and we want to get this settled in time for August submission, as Sarah mentioned a couple of minutes ago. And I'll go over that. So Michelle, while I'm going over this work plan, can you kind of prep that OAR draft PDF?
Yes, I will.
Thanks. All right. So we'll send the temporary rule language out to you for March discussion. We will go over an outline after finishing this schedule. So you can see we're devoting most of the year, rightfully so, to talking about how we want the submission template, the specification, and figuring out all of the quirks and the facts documents for this first data submission. Can you scroll down, Michelle? Yeah, so I guess the big highlights for us is March, you'll get temporary rule language. May,
Trang,
yes.
Sorry, Trang, can I jump in?
Yeah.
The column on the far right is when we hope to have final versions of those. So you'll get iterations of those for every meeting, but the column on the right is when we hope to have it completed.
Okay. All right. Thanks. So you'll see all of this we will aim to have in place. This spring, summer will be pretty busy for data submission related documents and figuring out all of those technical questions so payers can submit data for August. And I guess that's all I'll say about that. Do you want to add anything, Sarah?
Yeah, I think we wanted to ask if folks had any questions or any concerns about the draft charter language or any questions about the proposed work plan. As Trang said, it's really focused on the rules and the data submission template. It will be iterative. We expect to review, bring specific questions, do some work, come back, bring you a new iteration for each of these deliverables. So any questions, any comments on either of these?
This is Drew from Providence again. Do we already have like a first draft of the template available to us? And has that been distributed?
Yes, when I sent the meeting materials out, there was a spreadsheet with the draft template. You can also find that on the meeting materials, on the web page. It is a very first draft.
Yes, and we'll actually be looking at it in a couple minutes. So Michelle, can you go to the next PDF you have up, tag OAR outline?
Hang on. I just want to make sure that we don't have any other questions
yeah.
about the charter or any concerns about the draft language or the scope or anything that we'll be doing as a group this year. I'm not seeing any hands or anyone jumping off mute, so I'm assuming that this is all very clear, hopefully clear. If you do have questions or concerns, particularly about the charter language, please send us an email and we will welcome your feedback on that. But if not, let's go ahead and move to our next agenda item, which is looking at the draft rules language. So let me provide a little bit of context and then Trang will walk through the details. So the legislation, the statute that established the cost growth target program directs us to, or gives us the authority to collect the data and do the reporting for the program. We do need to establish Oregon administrative rules for the data submission process itself. We want to do this in 2 steps. We want to do temporary rules, which we can do fairly quickly and easily. They don't require the full rules advisory committee process, but we do want to get your input as the tag into those temporary rules. We want to stand up the temporary rules and have them to govern the data submission for the 2018 to 2020 data that I talked about as sort of that first baseline pass. We will then have final rules, hopefully this fall, October or November, and that will go through the formal process with the Rules Advisory Council and all of the sort of public engagement around that. Our hope is that we work out most of the details of the rules now with your input because you will be the data submitters. So in some ways you're providing rules advisory feedback unofficially, but that we don't expect there to be a ton of changes between the temporary rules and the final rules. If we learn anything from this initial data submission, if we find out that we missed anything or anything went sideways, we would have the opportunity to correct that before the final rules are established this fall. But that is our plan and the rough timeline, we want to talk about the outline for the rules and what would be in them today. And then in our March meeting, we'd go much more in depth into the actual rules language. Trey?
Thanks. So you can see we have a rough outline. These rules mirror our all payer, all claims database rules a little bit, but they are slightly shifted for 889. So really roughly, we have laid out for you the separate sections in the rule and some brief notes on big things we want to cover in them. So for example, in general reporting requirements, we'll talk about, you know, who is a mandatory reporter for 889, what lines of business are included, what lines of business are excluded, things like that. We'll also work with the tag to finalize that language and to also hammer out how first-time reporters will receive training or orientation, anything like that. Of course, for this first year, we do plan on holding events like webinars, office hours, other events aside from these tag meetings for reporters. The next section are the submission requirements. Here, we are going to refer to submission documents like the specifications, the data template. But aside from that, we'll outline the submission schedule and as we noted before, the process of submitting prior data if a reporter is going to be changing their risk adjustment methodology or their provider attribution. So that is this section. And if you can scroll down. Thanks. So the last couple section, one is on waivers and exemptions. In this section, we'll talk about the conditions under which a waiver can be applied, extensions, exceptions for certain reporting requirements. We understand that your payer data systems, they do not look the same, and you know, reporting a specific type of data in your organization might require a little more finessing, or maybe it's not feasible. So this is where we'll outline the process for that. And we do want to work with the tag, and we'll talk about when year is locked and when waivers and extensions and stuff, when the deadlines for those are. And after that, this is the compliance and enforcement section. So this specifies, you know, first of all, what is failure to comply with reporting requirements, and establishes civil penalties for that. I also want to note this is not the same thing as the PIP, the Performance Improvement Plan. This is just compliance and enforcement for data reporting. And the last section is data access and disclosure. So this will be language on what OHA will report on, if there is a public use data file, which we'll want discussion with folks on next month. What would that look like? And a lot of this rule language will come from the implementation committee report, like thresholds for reportings for provider organizations, stuff like that.
Similarly, the implementation committee recommended modeling the all payer, all claims civil penalty approach for failure to reporting. So that section will look very similar to the current APAC rules and civil penalties. So this is just the rough outline of what the rules are. Our plan is to have draft rule language that will circulate with specific questions flagged for discussion at the March meeting. The public use data file is one of those questions. This is something that's in APAC rules. We know that there are likely going to be folks interested in using this data as well for a lot of reasons. And we want to talk about what the right level of detail is for public use data files. And that's separate from any public facing reports that would be developed using the data. So given that as the outline and knowing that we'll get much more into the details next month, are there any questions or thoughts about the rules outline?
Hi, this is Bernie Inskeep, United Healthcare. I just had a quick question. Is this distinct and separate from the Appendix 1 and 2 for APAC, or does this replace it, or this is just in addition?
This is distinct and separate.
Okay.
I think we had, for context, we had some conversation internally and with the Department of Justice, and we went back and forth on, should we make this part of the APAC rule, and can we merge this all together with the APAC data submission? Again, looking at Massachusetts program, they have their cost growth target and their all payer data submissions sort of all bundled together. We are doing this separately. So we're trying to borrow as much as we can from APAC in terms of what we've learned about process and rule language and considerations, but it is separate. And the list of mandatory reporters for the cost growth target program is slightly different than the list of mandatory reporters for the all payer claims data. Other thoughts or questions?
All right. Well, the charter and work plan and the OAR outline are all listed under the 889 tag meeting for today. So please visit the website or your tag invite. It should be there too. Can we go to the next slide? And we're on the milestones. Yes. Okay. Thanks. So this is just a summary of what we're aiming for this year. So you can see a lot of it matches up with the 2021 work plan. And yeah, aiming for that August 2021 data submission, which will include 2018 to 2020 payer data. Do we want to?
Yep, just pause again to make sure, see if anyone has any other questions or comments before we start looking at the template itself. Does this cadence and timeline all generally make sense to you?
This is Kristen from Providence. I'll just put this on the record. I mean, especially during session, this is an aggressive timeline. I'm not saying it's not possible, but just putting that out there.
Kristen, thank you for noting that on the record. Are there any specifics that you're concerned about? Are you more concerned about the rules or the data submission or just everything in general?
I would say both are aggressive. I haven't seen, or we haven't really dug into the rules, so I guess it depends on how much of it is a brand new lift and how much of it would have to run through in terms of internal stakeholders not understanding where we're headed with this or needing to know more about capacity issues. So I think we have to dig into it a little bit more. I'm not, again, we're in this to be collaborative. I'm just stating it for the record that it seems aggressive.
Yeah, this is Jared from Cambia. I think we've had similar concerns, and as I look at it, looking at if the final technical specs aren't available till May, and then putting out a process to submit data and submitting multiple years of data, that time period looks a little tight. Based on just an initial view.
This is Drew. I hope it doesn't feel like we're piling on, but
one aspect to the timeline is for this first submissions, or it doesn't allow for iterative back and forth. I mean, there's going to be, as you noted, there will be sessions for us to work out questions, but truth is, you know, going from May to August, we're going to be feverishly coding and doing things. Oh,
Drew, let me jump in on that. I think we probably could have done a slightly better job explaining that August 2021 is the initial submission of the 18 to 20 file. We absolutely anticipate that there will be some need to go back and forth after that. So I don't know when the actual 18 to 20 data will be considered final. I think Megan has advised us, especially the experience that other states have had, our experience with the APAC file development. This could take multiple months after August in going back and forth and getting that final file to a good place. You'll see that we have essentially a year before the official 2021 data submission. So hopefully most of those kinks would be worked out. The August would be the deadline for the initial file, which hopefully would be of fairly good quality, but of course there would be details to be worked out and we would go back and forth after that. It's not that there would be multiple iterations and then final in August. Does that help?
it does help, but thank you for clarifying that.
Yeah, I think we are under a little bit of pressure from the committee, the policy board, stakeholder engagement in terms of how soon can we get a report and understand the 18 to 20 baseline, but obviously we need to make sure that that data submission is of good quality and that we're all comfortable with the data before we start using it and reporting out. So definitely a couple months of iteration in there, but just noting that we do have some pressure. Megan, is there anything you'd reflect on from the Rhode Island and Delaware experience with their initial file?
No, I think you hit on it, Sarah. There is definitely some need once an initial submission is done to do some validation and to have conversations to ensure that there was a mutual understanding of the specifications. That being said, the payers in Rhode Island and Delaware that we have worked with did not have challenges getting an initial submission in about 8 to 10 weeks after they received the final specifications. You are participating in the development of the specifications in some sense through this group, so you're going to have an earlier look at what data are being requested of you. And if you have the individuals who might be responsible for developing these data files on your end, participating in this group, there'll be a shared understanding, and it might actually make the back end of the process be a little bit more efficient, and perhaps the front end, have cleaner data to begin with. So this is all kind of expected as part of the process, and this pre-benchmark time period or pre-target time period is really, also practice for this process. And then hopefully as the years go on, it will become more of a routine request that you receive. And it'll become more routine for you and for the state.
And the implementation committee and stakeholder engagement throughout the process last year reflected multiple times that we needed to make sure that we had a ramp up period for this, that we had time to practice, that we had time to validate and work out the kinks of the data before we have that first official measurement year and before we get into any of the accountability mechanisms, which are even further downstream. So this is the very first step. Jared, Kristen, others, does that give you any reassurance? How are you feeling about the timeline with some of those clarifications?
I think those are good clarifications, and it, we're still working out the final rules, right? So it sort of depends.
Yeah, and I think, I know a number of you are familiar with the APAC rules, so I want to note that I think the rules for the cost growth target program will be lighter than the APAC rules. They will say, here's who needs to report, here's when the reporting is due, and then they will reference the specification template. So I think the rules are actually fairly straightforward. It's the template and the specifications, which we'll be working on starting in a couple of weeks, if not today, that will really be where the bulk of the content is. Other comments or questions from anyone? Jim?
I'm new to this group, but I'm curious. There are many different types of data submissions that we all do in our worlds in managed care today across all spectrums, Medicaid, Medicare, commercial. You reference APEC a couple times, and we're talking about this group trying to get this healthcare cost growth target program up and running. I'm just curious to know, in its simplicity, and I just figured I'd take the opportunity to ask it. Don't we have an ingestion of enough data to be able to allow extraction this way to already take place without having to create a new template like we're doing? And if you're laughing, I see you smile.
This is an excellent question that has come up multiple times. The short answer is no. We do not have all the detail we need in the APAC file. And we can go in more into the details, but we do require new data to be able to calculate the cost growth target in the way that the committee has specified.
Fair enough. I know from, and Medicaid specifically, and I've been doing it for many years here in Oregon. Yeah, I maybe be jaded in one side because we do give the program a lot of information all automatically, but okay, cool. I'm looking forward to hearing that, and I appreciate your comment.
And Jim, and I think Jim and Dean, for you as CCOs, I want to note that I think the CCO submission process might look a little different than it will for the non-CCO payers. There are some data files that OHA will prepare using data we have. So for example, we were talking internally yesterday about OHA will prepare a pharmacy rebate data file because most of the pharmacy rebate data happens at the state level, not at the CCO level. So there is some nuance to the CCO report, but for the most part, we do need information that we don't have currently.
Thank you very much. Appreciate it.
Other.
Hey, Sarah, I have a question that really goes back all the way to the earlier slides, which it's asking for if any consideration will be given to changes in state mandated benefits or benefits change mandated by CMS, or even things like changes in, well, I'll just leave it at that.
Yep. Changes
in mandated benefits, because I mean, the legislative session is jamming a lot of new expectations.
So, are you asking how we incorporate that in the data submission, or how that's incorporated in the cost growth target program process in general?
Kind of both, and if you don't have an answer, that's also okay. I just want to be on that's a concern.
Totally. I think my short answer, and team, jump in if you don't agree with my gut reaction on this, we will not try to incorporate that in the data submission. The data submission sort of is what it is. It's total expenditures. Those expenditures may be impacted by, as you say, changes in mandated benefits, pandemics, all kinds of other things. After the data have been submitted, validated, the cost growth target performance has been calculated, the committee has outlined a whole process of back and forth with each payer and provider in reviewing the data and understanding why. So as a technical group, we're focused on making sure the data are clean and validated and good quality and ready for those conversations about why. But that taking into consideration those changes and other factors is all built into the process after the initial calculation and before any accountability is determined. And if you haven't seen it, I can point you all to the section of the recommendations report and an educational webinar that we did for the policy board that outlines that part of the cost growth target process in a lot more detail and all the steps and back and forth that happen then. But again, that's all after the data have been submitted.
Understood. Thank you.
Other thoughts? I mean, I'm starting to feel a little awkward, like in a way, because I feel like I'm trying to silo this out really cleanly. Like all we care about is the data submission, but in some ways, like, yes, that is the primary focus, but there is this much broader context of the whole program and all the other process steps. So I don't want to negate that. I just want to be really careful of like keeping the technical group in our lane on the technical side of things, knowing that some of this has already been worked out by the committee. Other thoughts? I know mostly we've been hearing from the payers, and since the payers are the ones that will be creating the data file and submitting it, that is probably really appropriate, but others on the phone, providers, stakeholders, any thoughts from you? Okay, let's go ahead and talk about the data submission template then. So this is an introduction, and I want to recognize that we only sent out the Excel file. We did not send out the sort of accompanying specifications and all of the detailed definitions and instructions. That will exist, that will accompany this in the future. We did not, it is not ready for sharing yet. So this is just the template. So I think for today, our intent is to just give you a little bit of orientation to the file, flag a couple of things that we want to have more discussion on in March, and then see if there are any initial questions or reactions. I'm not thinking that we make any decisions today or that we make any changes or put you on the spot for giving us your official preference on any of this, on any of these questions. So with that as some framing, Trang and Yishan, do you want to walk us through the template?
Yes, sure. And Yishan, you could feel free to jump in or follow up. So you can see the template is pretty simple. This is still the draft form, but it's organized into 3 separate tabs for provider, TME, pharmacy rebate, and market enrollment. If you scroll right, Michelle, so folks can see, there's a couple columns at the end there's a couple columns at the end where you'll see OHA has inserted some auto calculations for you. So this is where you'll see how we will summarize, aggregate the data for program use. So, and if you go into one of those cells, you could see the formula for that. Somebody in the meeting earlier had a question about how we record unattributed folks. And I'm wondering if you scroll back to the left, Michelle, and you could explore this on your own too. But Yishan, that should be one of the drop downs, right? For provider attribution type.
Yes, that would be the column BE, TME02. So if Michelle, if you can click maybe column B, one of the element, and maybe row 9.
Yeah, go to row 9, B9.
Yeah, and you can click the drop down list. And yeah, so for all the members which is unable to attribute it to a provider, then you can select all other and report it in one aggregate line. Yeah.
All right. If you can go to the pharmacy rebate tab.
Actually, before going off that tab, I just had a question. This is Jared from Cambia again for reference. I was looking at some of the ways that the costs were split out, and I noted in your on the spec tab, there's a description of some of the specialties or types of services that are expected. In the full spec file that you're talking about, are you going to have references to standard code sets that we can leverage to understand and improve consistency across submissions? I'm thinking of things like place of service, where CMS has the standard codes, and so you'll have the codes where we can identify what you mean by different services that are referenced.
Yes, absolutely.
And
there will be a lot more detail about each of these fields and codes where it makes sense to give direction. I think recognizing that we want to standardize as much as possible across these submissions, there may be some places where there is some noise, but yes.
And was there any thought onto, as you think about trends, there's common types of services that may have more interest than others. And as I looked through, it was unclear where things like dialysis or medical drugs or things like that might show up. And so I just would suggest that there might be some other categories that may make sense. But not sure if you've thought through things like that. So
yeah,
I guess the question would be of, medical drugs often get lots of attention. It was unclear to me which category, or if it's split across multiple categories, and that seems like a potential challenge.
That's a great flag, Jared. And I think, I guess this might be a question for the whole group. And Megan, I'd love to hear if this came up in other states too, but I think what we're looking at in this template is some high level stratification by category. And so we can define where something like dialysis fits in those categories. But if we wanted to do a deeper dive analysis and look at trends and maybe changes in price or changes in utilization for one of those specific services directly, we wouldn't expect this file to provide all of the granularity that we would need. We would go to the all payer claims database for that. We would work with payers and providers directly to do some analysis, maybe with your own in-house data, depending on the question and the scope. So I think, again, this is one of those threading the needle where we want some level of stratification here, but it will not be comprehensive to answer all questions. And that's when we would rely on APAC. Megan, do you have context for us?
Yeah, so actually, I think, Sarah, you hit the nail on the head there. This is meant to give a first look to then identify what are the areas that need to be explored. And then using, and luckily Oregon is a data-rich state. And so you can use other data sources that you all are participating in for OHA to sort of dig in deeper. I think, the distinction between medical and retail pharmacy is a really important distinction to make. And that should be either in a definition or a code level detail for this information, and that you can categorize it correctly. This will never be the end all be all look to identify every single service, but maybe there are, really important ones that want to be called out separately, or maybe there's some comfort with having larger groupings to at least get an overall sense of where the costs lie.
Thanks, Megan.
And that's great. I appreciate your validating that you'll be using standard code sets, and the more of those that show up, I think the easier it'll be for us to code and develop it and make sure that our reports are consistent with what you're expecting.
Great.
This is Drew. I have a question about column R and column S. If we could scroll that way.
Yeah, Michelle, can you scroll right, please?
So first question, the total non-claims expense, just want to clarify, that's total non-claims benefit expense, right? Not administrative costs, or just benefit expense, things that a member would benefit from.
Total dollars paid out to a provider.
Okay.
that were not on a claim. So that could be a number of value-based payment arrangements, incentive funds, other services, all of that's rolled up.
All right. But maybe like a delegated administrative function, or maybe we should just clarify, like if we have delegated administrative functions that go to providers, that wouldn't be there. Or would it?
I want to say no, but I think we need a better way to make sure that we're capturing any delegated administrative costs. But Megan, you're laughing.
No. So delegated administrative costs would come out of the net cost of private health insurance. Mm-hmm. So when you simply take premiums less claims, what is left over could be used to pay for delegated services. This gets particularly confusing when, for example, in some states they ask for PMPM care management payments. Those aren't specifically the delegated services of care management functions that an insurer would do, but they are for, PMPM to support populations with increased illness burden, like diabetes, for example. So I think when this is fully defined, it should be clearer.
Okay. So I was thinking like delegated utilization management function. Some of our providers get a cap amount for delegated utilization management. It seems to me that that would be excluded, because if we had not delegated, it just would have been in the health plan's administrative function.
Right, that's correct, and we don't want to capture that information twice, since it will be part of what's considered the net cost of private health insurance.
Okay, thank you. Mm-hmm. One more, so a couple more questions on the total non-claims expense. I assume, or would this is where capitated expense would go, like if we had at one point, if let's say we had outsourced behavioral health services or outsourced some other service like vision or dental, that would be captured there?
Yes, but to some extent, some of this is where, because this is being broken down at the provider, for a provider organization. So if you were delegating, if you would outsource behavioral health, you would have, let me try to answer this again. This is based on reporting for the provider organizations that meet the criteria for provider organizations. And so we're not focusing on specialty like vision. So you wouldn't necessarily list every vision service provider that you may have outsourced services to. If you are making payments to a health system or a medical group, and that includes some payments for vision services, regardless of how that's structured, that might be captured. But again, this is going through that primary care-based attribution to the organization. Did that make sense at all?
It didn't, honestly.
Fair enough. Megan, can you try?
So no vendor payments should be in the spreadsheet, period. So if you're making capitated payments to a vendor as a carve out, that should not go in here. It is directly payments that are made to a provider organization. There's no, like, you might have, I know in one case in one of the states I worked in, there was a vendor payment for some sort of gym membership, and because it was considered to be an individual patient or member base, they included it. That's not the type of expenses that should be in here. And Sarah, if I'm not mistaken, do you separate out non-claims? I don't know if you made a decision to make different distinctions of the buckets, or is it one bucket? Because I wonder if it makes sense to go through there. It's one bucket.
It's one bucket today. I think given this conversation, we might want to talk about this more in March. So to the earlier comment about streamlining and using existing data sources, Oregon is data rich in that we have the payment arrangement file for the all payer claims database. And we have a lot more detail about different payment arrangements in that payment arrangement file. And so we've been going back and forth internally about, do we just have column R that's all non-claims expenses in one lump category? Or do we have a number of subcategories that might get into some of that granularity, even if some of that is duplicative of what we have in the payment arrangement file? We're leaning towards not duplicating, which would let us look at trends through the payment arrangement file and the APAC reporting, but it wouldn't be an exact match to the cost growth target program structure. But I think if there are a lot of concerns about this, or if we feel like we would need more ability to look under the hood specifically, we could consider breaking that out.
And Sarah and Megan, something you've said is confusing me a little bit more, which is if it's payments just to providers. So for example, let's say we carved out behavioral health services. The row would reflect members who are attributed, say, to Legacy Health, and they have total costs there, including behavioral health costs. But the health plan had outsourced behavioral health costs to some vendor. Are we not to include those costs because that was a cap payment that went out to, let's say Optum?
Again,
yeah. So we do not. Well, let me say that I'll explain what other states are doing, and I would anticipate that through these conversations, we can clarify this further in Oregon. Capitated payments to vendors are not included. That being said, there may be significant amount of services that are carved out, pharmacy being another one, in addition to behavioral health, and some certain high cost services maybe too. In other states, it's incumbent upon the payer to make an estimation if they don't have access to the specific data. And what they typically have done is is look at other either similar populations where maybe they hold that benefit, or make an estimation as best they can of what that spending would be rather than the capitated payment. Because
Megan, and can I ask why the other states decided to do the estimation route rather than just adding another row or tab in their data collection for capitated payments to vendors?
Because it doesn't adequately capture. So the part of the capitated payment to a vendor is both the price for the service that, for example, in this case, Optum would provide to the provider, plus an admin expense. And you'd end up duplicating that because you're also measuring the net cost of private health insurance, where that admin expense also may be. And frankly, many of the payers aren't able to access anything more than the capitated amount. So they don't necessarily know how much of their cap is actually profit to the carve-out vendor.
The vendor.
This is
estimating.
I'll just be on record. This seems like a hole that I'd like to spend more time on another day, because I mean, we're going to, between pharmacy expense, behavioral health expense, and a whole bunch of other expenses that all our carriers probably have at one point either outsourced and insourced. Just changes between those outsourcing and insourcing was going to create these huge distortions, which we'll spend paragraph after paragraph just trying to explain, as opposed to managing it through the data.
Drew, thank you for stating that, and I agree we should talk more about that. Maybe we can bring this back in March, but can I ask all of you who do outsource to vendors for this, how much line of sight do you have into how those services, what they're paying for? Do you have a cap on admin as part of that contract? Are you seeing into the claims essentially, or is it kind of a black box?
I mean, it depends. Some of it is a black box. It's a some is just a payment per head, and their risk margin is their risk margin. And if the spend is way over that, the fee for service equivalent spend, well, then they didn't have any margin, right? And if it's way under that, then it was all margin. So it's kind of an irrelevant. I mean, they would argue back it's an irrelevant question. We don't get to see their underwriting. Is really, I think, what you're asking. What does their underwriting file look like?
And you're also not seeing the encounters either.
Well, we are getting the encounters. That is true. We are getting the encounters.
And Megan, are the other states using encounters to do some of that estimating, for example?
It depends on the payer. Most states have given some flexibility. I will say that, Drew, do you represent a CCO?
I don't. I represent, I represent a health plan that has commercial Medicare and Medicaid. We participate in as part of a CCO.
Okay, so well, commercial payers in the other states, what they do is they basically estimate what the spending on the what they're calling like a full claims population, where they hold the entire medical benefit and everything else, and then they take what's called partial claims, where they have, you know, something is carved out, and they make a risk adjusted estimation based on their full claims portion. I think it's a little trickier in the Medicaid or Medicare line of business, just because you don't necessarily have that built-in population where you might have that all not carved out, I think. But other states are basically using their own data, and the formulas for making those estimates have varied.
So it sounds like this is something we should explore more. I'd like to spend some time with the team internally to think about options. I think one is sort of what level of detail this gets captured at. One is presenting some options for you all to reflect on in March about various approaches to estimation. And I kind of want to poke at a little bit more to see, is there an adjustment we could make to the net cost of private health insurance that would somehow let us take more of this into consideration? So it sounds like we could do a little bit more thinking on this behind the scenes and come back in March for more discussion.
And can I ask one more question on this topic, since you're going to be considering it? You know, when I was reading through the non-claims expense, this is Jared from Cambia again, by the way, there were notes that it could be to a provider or organization. So it did make it sound like engagements with vendors to manage certain specific conditions, where they do reach out to the members and help them coordinate care and get effective care and whatever. And there are monthly payments to those vendors or other incentive deals. Those you're saying would not be included?
So maybe to take a quick step back, and hopefully I won't cause more confusion, Megan, be ready to bail me out here, but we're not thinking that this data submission template is one row for every single entity that you as a payer pay. This will be a subset of those provider organizations that meet the criteria. So it'll be the large health systems, Legacy, Kaiser, Providence. It'll be the large medical groups. It will not be every single vendor that you contract with. So does that make sense? So in some ways, it's kind of a moot question, because those costs, you're not paying those vendor dollars to those provider organizations.
But sorry, that doesn't make sense, Sarah, because I thought it was about the cost for the member who is attributed to those provider organizations. And those members are going to see providers all over the spectrum across Oregon and Southwest Washington and Idaho. And a lot of those claims, maybe even 80% of those claims, won't be tied back to the provider who they were attributed to. They saw a PCP at Legacy or OHSU or Providence, but their 80% of their spend is going to be elsewhere.
And so this is where the other states are doing the estimation, where if they're seeing a vendor that is getting that capitated payment, they're estimating the equivalent claims amount and adding it to the total. Is that accurate, Megan? Because they are seeing those vendors.
Unfortunately, no, I don't think that's how I would describe it. Okay. So essentially all of the dollars that are attributed to an individual patient need to be attributed to a provider organization. If you can attribute, I mean, vendor payments aren't typically attributed to, I should say not typically, but some vendor payments can't be attributed to an individual patient. There may be a population that you're paying a vendor to manage, and you're not sure exactly which of the patients are receiving those services. The issue at hand, though, when it comes to the non-claims, is there is a measurement of the net cost of private health insurance. And that is essentially looking at all of the admin expenses that an insurer has. And you do not want to duplicate what is in what's in the net cost of private health insurance and the non-claims. Otherwise, you're getting, in a sense, you're double counting those particular services. That being said, when you have something that's carved out, and it is a medical benefit, it's a behavioral health benefit, it's a pharmacy benefit, there needs to be some sort of estimation back down to that individual patient level, so that those costs can be attributed to the provider organization.
again, that makes sense, which is why I was trying to figure out where does something like a capitated payment for pharmacy or behavioral health fall.
So it sounds like maybe for March, Sarah, talking about what kinds of estimations could be done across the different lines of business, and whether that's the right approach to go could potentially be a topic for consideration.
Yep, and maybe we can walk through where various types of capitated payments for both carve out, carve in, and integrated setups would factor into this spreadsheet.
This is Zachary from OHA. You know, it could be that some of these vendor payments are attributable, because if you have the encounter data, maybe you can slice and dice it and put them in the right buckets for that attributed clinic or provider group or health system, whoever it is. But potentially other vendor payments aren't attributable. There's no way to allocate, you know, 5% here, 12% there. Yeah, there's likely going to be some variation that we'll have to figure out.
And
go ahead, Drew.
Sorry, it's I think Zachary is confusing me one more time. That it's not that I don't think the ask is for us to allocate the payment to a provider based on the servicing. Let's take pharmacy expense. Almost all of that, 99% of that pharmacy expense is going to be retail pharmacy. But that's for members who are attributed to one of those large integrated delivery systems. We need to show, I'm assuming you want us to show that pharmacy expense, even if it's carved out in a PBM cap arrangement in column R, and somehow carve out the admit expense that we're paying to the PBM.
Oh, so other states don't put it in column R, other states put it into the pharmacy services, and they do not put the admin into the column R. They say, this is what it would look like if we paid for pharmacy for those members to whom we've carved out to a PBM, as if we were actually the ones paying the claims. It's an estimate. Again, this is the purpose of this is to give you a sense of spending, a transparent way of looking at cost growth, and then give you ideas of where to go digging further to really dive in and understand what's driving that. And
so given this conversation, I mean, it feels like this actually feels like evidence for splitting out column R into some of the subcategories so that we can have tighter bands around what's being captured there. And I mean, obviously there'll be tighter bands and definitions in the specifications, but I think that's not necessarily like an everything else placeholder bucket. Those column R is specific kinds of payments, and maybe spelling that out more clearly and having some of that stratification would actually be more helpful.
And can I ask one more question on that? Like, please. I was looking at some of the examples in the Excel file of, you know, quality or achieving quality targets, right? Those would count. But are you saying that quality payment's not tied to the attributed members, but it's tied to the organization they were attributed to? Or is the quality, for example, we've got quality programs that are tied to providers across the spectrum, not just primary care physicians, and that link is really unclear how those quality payments made to providers would actually show up. Does that question make sense, whether it's tied to the attributed member or tied to the organization where they were attributed to? And if it's the latter, feels like there's a large dollar or a large bucket of dollars we pay to organizations that wouldn't show up here, but it sounds like the intent is for them to show up. So I'm just maybe agreeing that a broader discussion would be helpful, and looking forward to seeing what you provide as additional detail or examples.
Yeah, Megan, I don't know if you have a quick answer for that, but I think in general, these are the kinds of questions that are super helpful in helping us figure out what needs more clarity and what needs to be more tightly defined or stratified in any direction. So please don't feel bad for all of these questions. This is really helpful.
Yeah, and I think actually on the flip side, also getting some examples from you on particular ways in which payments are made can help clarify that. So for example, if one of these rows was Acme IPA and you paid a quality bonus to them for their effort, we would expect to see that in the non-claims expense. However, if you pay Acme IPA's quality bonus to larger parent organization B, there will probably, and because the number of integrated organizations in the state, there might need to be some tighter rules around how to handle those situations. And then finally, I would anticipate that you have payers have few, but it could exist where you have actually quality dollars attached to a particular member, maybe for conditions. But I think more often than not, it's probably attached to the provider level, which should be easily attributed and displayed in this way too.
So it's possible that we actually either need to clarify that column R includes all of these things added up or split them out separately, because Megan, in your answer, it sounds like we would want the report on both quality dollars attached to a member that could be attributed to that organization and quality dollars that went to that provider organization. Both should be captured.
Yes, for sure. I would assume that the former, attributing it to individuals, is less likely in terms of incentive programs, but that's where having some feedback from this group to say, this is the arrangement that I have, how could I report that to make sure that everyone is clear and it's well documented on how to do that.
Jared, does that help?
Partially. I think my question is more a concern that we might have, some quality program for a specialty group, right? And because it's a primary care attribution model, they just don't overlap, right? And so if we have a specialty group with quality payments, that particular group wouldn't show up anywhere here. Or a hospital that doesn't have primary care groups, which may not apply in Oregon. I'm not entirely sure. I'd have to look, but
all of those dollars should be attributed. So as we said in the beginning, I think when Michelle showed that B9 or whatever, it's all dollars that can be attributed to the organizations listed, and then finally all unattributed dollars. So any sort of quality payment to a specialist group that can't be attributed to a primary care provider or an individual patient would go into that bucket. So you would capture it in a giant sort of one row as part of this. So yes, those dollars need to be counted
for.
So
that other row is sort of everything else, but not necessarily tied to unattributed members, right? That's what you're saying?
It's both. It's both unattributed members and everything else. So we actually had gone back and forth on, and I really struggled with this because it feels like we needed to have a payer tab where sort of the payer reports all those total unattributed costs and then the provider costs, because not all costs are going to be attributed to an organization. And we've ultimately landed where it is just one tab, but there is going to sort of be that other row, and that will be everything else. It is not a provider organization. It's the costs that cannot be attributed.
So even though the member is attributed, if the payment was to a provider that wasn't in that MPI or TIN, it goes into an other attributed row.
Say that again. I'm not sure I follow that. If the members attributed, all costs for them should go in that row, right? It's only if the member can't be attributed.
Or the expense, that is, I guess. The member, so some of that expense for that pay for performance program is, if it's not possible to break it out at the member level, then it goes into an unattributed row.
I think that's fair to say that that unattributed row not only is unidentified providers as well as unattributed members.
Okay.
Richard, you've got your hand up.
Yeah, thanks, Sarah. Richard Gibson from Comagine Health. In column B, with TME 02, you have the two drop downs. Members are attributed to provider entity and then all other. But really, number one there means members that are attributed to a PCP provider entity, as opposed to just saying, I got a cardiologist service from a cardiologist at OHSU or at Legacy. That we're talking about members that are attributed to a PCP for all of their care. Is that a correct interpretation of one, the drop down one under TME?
No, I don't think that's quite right. And again, Megan, please jump in here. I think it's members who are attributed to a qualifying organization using a primary care-based attribution method.
Right. Okay, that's what I mean. But we're really talking about attributed to a provider entity via a PCP.
Yes.
Yes.
Okay. Good, thank you. So that if a person saw a cardiologist at OHSU, but that payer was unable to attribute that patient to PCP in any health system, that would go under drop down 2 in the next line.
All other. Yeah.
Good, thank you.
Yes, I feel like that was too easy. Was that the correct answer?
It was.
Thanks.
I realize I may be hogging up a lot of time here, but column S also kind of has me uncertain about expectations there. Is this the standard deviation at the person level? At what level is the standard deviation calculated there?
I'm going to ask if we can hold this conversation to March, because I think we need to introduce more about the why we're asking for this and the options rather than just answering you now. I think, Drew, we've been struggling with this internally, but I'd like to give it more context before we jump into a discussion, if that's okay.
Fine by me.
Okay. This is the kind of conversation that we want to keep having in March. We will provide an updated version of the template if we have one for the next meeting, plus any specific questions or pieces of documentation or prompts that we want to walk through with you all. This kind of in the weeds detail is exactly what we hope to spend time doing in this group. So this was a great first start to the conversation. Are there any other questions or comments that anyone wants to get out there or add to the record or flag for the March conversation?
I had one note as you were talking about the data submission. You know, as you think about 18, 19, and 20, for 2020, there would only be 6 months of run out, but the prior 2 years would have complete run out. So there might be some differences. It sounds like if you can estimate IBNR, not clear where that shows up, if it shows up in a non-claimed expense or within buckets, like that would be helpful to just ensure that you have clarification on. I did have a question on the no negative value comment. That seems to indicate you only want to receive like the final claim. I guess if it's an annual submission and it's fixed, it's less important. I was considering your claims adjustments and things. I was also curious if you had thoughts about minimum number of attribution to report on a specific provider. So hopefully you can comment on that in the specs.
Yeah, so the attribution for the provider, that is more straightforward. We have guidance from the implementation committee
okay, perfect.
on thresholds for provider size and organization. We're also working on a preliminary list of which providers we think will meet the threshold. And this is a proxy using APAC. It's obviously not your own payer attribution. So it is just going to be a placeholder, but we can share that hopefully for the March meeting, and that might give a little bit more clarity.
Great, looking forward to it.
Any comments on Jared's first two questions?
Yeah, oh, sorry, I don't know if you were directing that back to the state team, but there's definitely going to be, or there can definitely be provider incentive arrangements that would be negative. Either loss of withhold or even in a full downside risk, which we've I mean, I can tell you for certain that Providence has negative, negative net impact provider incentive arrangements.
Okay. We will look back into that. Thank you.
And Sarah, you might want to add a note about recovery payments too.
Yeah, yep, thanks. Okay, I think I'm going to wrap us up a little bit early. Just some thoughts. I think you have the draft rules outline, you have the draft template. Again, this is very drafty and does not include the accompanying specifications with all the detail. If you continue to look at this over the next couple of weeks and have questions or want to flag things for discussion, please send us an email. We welcome your feedback. All of this is giving us really helpful guidance in terms of what to flesh out and what needs more discussion with the full group. So please feel free to keep sending thoughts this way. Shrang, you want to share comments for the next meeting?
Sure, yeah. So for the next meeting, we'll forward the invite. You have the date and time on the slide right now. So we'll forward it to the distribution list we have right now, and feel free to send it to other team members, staff on your side. The audio for this meeting will be posted under the February 24th tag meeting. And I think those are the notes I have now. March will be a much more substantial meeting with the rule language, definitely this data template. So please, yeah, review all the materials. And I know we didn't get a chance to throw up the tag charter, but that is also listed, and we kind of like went over what the membership and scope and charge of the tag is, and how and we can talk later about how this kind of plugs into the implementation committee and the future governance committee.
Thanks, Trang. Any final comments or questions from anyone? All right. Thank you everyone so much for participating. We look forward to continuing this conversation in March. Have a great day.
Thank you.
Right. Bye, everyone.